Hi, this is Lisa Schwanke from Iowa Association of Community Providers. We're presenting a webinar on the prevention of Medicaid waste, fraud, and abuse. What we're going to cover in this webinar is definitions, potential penalties, prevention, and reporting requirements. So the first definition we're talking about is Medicaid fraud, and what's important in this definition is the intentional part. Medicaid fraud is always going to be intentional. It's someone choosing to do something that benefits himself or another through deception around Medicaid. Abuse, on the other hand, is provider practices that are inconsistent with sound fiscal, business, or medical practices that result in unnecessary costs. So again, there's intention. The person very much knows that this isn't how things are typically done or should be done, or they're providing services in a way that doesn't meet professionally recognized standards for health care. In all these instances, it's intentional. The person chooses to provide services that are substandard, or they practice business practices that don't meet general acceptable practices. There are several types of fraud and abuse. They include billing for services not covered, identity theft, billing services not provided, kickbacks, unbundling, upcoding, and unnecessary services. So billing for services not covered, that's why we always talk about assuring that you know the scope of the service that you're providing, that you're clear on what you can and cannot provide as part of that service. You can't have a situation where you say, okay, this isn't part of this service, so we're going to provide it, but we're just not going to tell anybody. That would be an intentional abuse of the service and could be considered fraud. So an example of that could be if you've chosen to provide transportation services to and from a day service under home-based habilitation. That's specifically excluded in home-based habilitation, so you can't provide that as part of the service. Identity theft, that's basically taking someone's ID number, their Title 19 number, and using it to bill for services that you didn't provide. You may not even know the person. Several years ago, there was a provider, a chiropractor in the state of Iowa, who obtained somehow a number of children's Medicaid numbers, and he set up a computer software system that automatically billed chiropractic services for all those children each month. Unfortunately, he failed to plug in holidays into his computer program, so when he billed for several children on Christmas Day, it raised red flags, and the state went back and did some checking, called the parents, found out that they not only did not take their child to these chiropractic appointments, they didn't even know the chiropractor who was billing for those services. So he's no longer practicing in Iowa. Billing for unnecessary services or items. Basically, the federal government allows states to put on some criteria around services. So one of those services is that services must be medically necessary. So all of our services need to tie back to the health need of the person. So due to their disability, why do they need this service? I think this is something we're really going to want to pay even closer attention to with the rollout of the managed care organizations. When we're working with them, getting authorizations for services, we're going to have to be able to clearly articulate why this person needs the service, and that the service need is based on their disability or their medical issue that they're dealing with. It can't be because they feel more comfortable if they have someone with them when they attend doctor's appointments. It needs to be something like they need someone to go with them to doctor's appointments because their anxiety levels are so high that they are not able to clearly articulate to their medical provider what their needs are, nor are they able to understand what the provider needs them to do, how they're to take their medications, whatever the case may be. Billing for services that are not rendered kind of sounds like a no-brainer, but it's really important that you only bill for services that were indeed provided. There was an example in Massachusetts where a personal care attendant was billing and saying that they provided services to someone while they were in the hospital, that they provided home health services. Not only did they say that they provided services while the person was in the hospital, they continued to say that they provided services to that person 7 months past the person's death. So obviously they didn't provide service after the person was deceased. They ended up being sentenced to 2 years probation and had to pay $10,000 back in medical restitution. Upcoding is another thing that you can't do. It's not a term defined by the federal government, but it's generally understood as billing for services at a level of complexity that is higher than the service actually provided or documented. There was a case in St. Louis where a psychiatrist consistently billed Medicaid for 20-minute sessions after only spending 5 minutes with people. What happened with that one is the psychiatrist and his employers agreed to pay back $441,000 to Medicaid. He pleaded guilty to making false statements to the FBI, and he was sent to prison for 5 months and forfeited an additional $100,000 and paid a fine of $30,000. So it's really just not worth it. Unbundling, that occurs when multiple procedure codes are billed for a group of procedures that are covered by a single comprehensive code. An example of that would be as if a doctor orders a panel of blood tests, typically that is billed as one panel, and instead of billing it for one panel, bills each one of the blood tests separately and therefore receives more money than if he had billed it as the panel. Billing for non-covered services or items. Fraud and abuse may involve services that are provided but not covered by Medicaid. Providers should only bill for medically necessary or otherwise authorized services or items actually furnished to the beneficiaries, and should ensure that proper documentation is in place. I think we've covered this in several of our trainings and several webinars. Again, emphasizing you need to only bill for services that are within the scope of the service and services that are authorized in each person's plan. Outside of that could be considered fraudulent if it's an intentional act. Kickbacks, I don't think this happens often in our business. Typically, this happens when a specialist may have an agreement with a general practitioner that for every person you refer to my practice, I will give you X amount of dollars. Again, doesn't happen very quickly in our services. There is a section in the day have services in Iowa Administrative Code that clearly says you can't pay people to attend day have services. So that would be a case of where if you had someone who you felt really would benefit from day have services and you just can't get them to see the need to come, and you think, okay, well maybe if we offered to pay them to come, they would come and they would see the benefit. That would be considered a kickback, and you can't do that. Medicaid waste is different from fraud and abuse in that most often it doesn't involve a violation of the law. It primarily relates to mismanagement, inappropriate actions, and inadequate oversight. Often waste occurs if staff don't know the scope of the service, so they're providing things outside the service, or if they're inadequately documenting the service, that could be a problem. And basically the biggest difference between waste versus fraud and abuse is that waste usually is unintentional. So it may be submitting an erroneous claim, but you didn't know that it was wrong. You know, the other thing that I think often happens is with waste is that people just don't know the rules. That's not going to be a defense if you're audited. Saying that I didn't know that we couldn't do that isn't going to prevent you from having to pay money back. It is probably going to prevent you from being charged with fraud. Improper payments arise as a result of clerical errors, misinterpretation of program rules, or inadequate or poor record keeping. Well, some of them could be considered fraud. So, for example, I was just talking about saying, you know what, I just didn't know. You know, the first time you say I just didn't know, they're going to most likely consider it waste and not fraud. But if you say that about everything and you very much do not make an effort to know the rules, that's going to be fraud. But if it's just an honest mistake, it's going to be viewed as waste. And that really is the vast majority of things that happen with Medicaid reimbursement. Most people are really trying to do the best that they can, but you're still going to pay the money back. Some examples of improper Medicaid payments, services not adequately documented. And what's important in all of these is to remember intent. You know, services that are inadequate or not adequately documented most often are always going to be waste because people truly are trying to document the way they need to be. However, if people intentionally don't document, that could fall into fraud. Incorrect coding with billing is another example. Service documentation not meeting Iowa's reimbursement rules and regulations as they're defined in Chapter 79.3. Failure to document time in and time out, data service, location, interventions, staff signature, those kind of things. Those are all part of Chapter 79. Errors in calculating units that result in overbilling or underbilling. So it's really important that who's ever billing your services understands the rounding rules for each services. Billing for supports and services that are prohibited by rule. Billing when the individual is hospitalized for 24 hours in a calendar day. That's something that I think can be difficult in our situations because we often serve people who need a lot of support, and folks in the hospital don't necessarily understand them well enough to provide that support. It's important to remember that if they're in the hospital, you're not going to be able to bill services 4 days that they were in the hospital for 24 hours. So you'll just need to make a decision on how you're going to work with the hospital to make sure that they get the support that they need. And then obviously completing documentation before providing services. This can be often be tempting because the folks that we serve often live very routine lives, as all of us do, and it's tempting to not complete documentation when we have time, especially if we have other obligations after we're finished with our shift. But completing documentation before actually providing the services is always going to be waste, and if it's done intentionally when you know that you shouldn't do it, it could also be considered fraud. So if you have some documentation that doesn't meet standard, and you find that through your quality assurance process, you can correct that documentation. And this slide shows how you must correct that documentation. It's important to recognize that whether you're doing electronic documentation or paper documentation, the original record has to stay there. A line needs to be drawn through it, and your electronic system has to keep it. And the person who made the change needs to sign and date the change. Penalties. Providers who engage in fraud and abuse, this is always a scary section of this presentation, are really subject to a lot of sanctions under federal and state laws. They can take the form of administrative or civil or criminal penalties, and they generally range from monetary fines and damages to prison time and exclusion from the federal health care programs, including Medicaid. In fiscal year 2014, the government's healthcare fraud enforcement efforts recovered more than $3 billion. They had 734 people convicted of healthcare fraud, and they prosecuted 105, or they charged 105 people with healthcare fraud-related crimes. In addition, each state has a Medicaid fraud control unit, and their report of 2014 showed 1,318 criminal convictions, 874 civil settlements. That led to 1,337 provider exclusions. So that was either people or agencies who were excluded from federal health care programs, and they recovered a total of $1.9 billion. Now those figures don't reflect the additional costs that I'm sure all of these folks who were charged with a crime spent on defending themselves, explaining what happened, and all those negotiations. So it's really critical that you have systems set in place in your agency to prevent waste, fraud, and abuse, so that there's never a question and that you never have to deal with a charge. So that leads us to how do we prevent it. Probably the best way to prevent it is to know the laws, know what is expected of each service, know how the documentation requirements, how you're supposed to bill, who you need to report fraud to. Probably the biggest thing you can do is screen for excluded individuals and then implement a compliance program. So under Section 1128 of the Social Security Act, OIG has the authority to exclude people from federal health care programs for various reasons. Mandatory exclusions are convictions of program-related crimes, convictions related to patient abuse, felony convictions related to healthcare fraud, and felony convictions related to controlled substances. So if any of those happen, if you are involved in any of those things, it's a mandatory exclusion. You will be excluded from participation in federal health care programs. There's also discretionary exclusions. So someone can be excluded because they lost a license to practice in the state. This one I didn't know. Failing to repay student loans, it does explain why in some local communities that I'm aware of, hospitals have recruited doctors and have paid off their student loans. Convictions of certain misdemeanors can lead to an exclusion, or failing to provide quality care can lead to exclusions. The federal government will not pay for items or services furnished, ordered, or prescribed or supplied by an excluded individual or entity. So if you employ someone who is excluded, you will have to pay back the money you receive for any services they provided, and you could also be sanctioned. CMS advises states to require providers to screen their employees and contractors both on the LEIE database and the SAM database on a monthly basis. Iowa does require that all providers screen all their staff monthly for this. If you have an audit through HCBS, they will ask for evidence to show that you are screening all your staff for this. And here are the links to those websites where you can screen staff. This slide is a section of the Medicaid provider agreement that talks about Medicaid waste, fraud, and abuse. It states that any agency that receives more than $5 million in Medicaid dollars must have policies and procedures around both training their staff on preventing waste, fraud, and abuse, but also their policies on how they prevent it. And they have to have something in their handbook, in their policies, that shows that employees are protected from retaliation if they do indeed say, hey, I think this is fraudulent, and report it. All providers really need to develop a strong Medicaid compliance program. That includes a corporate compliance policy with codes of ethical conduct, monitoring for Medicaid waste, fraud, and abuse, and taking appropriate actions if you find something, monitoring to ensure program integrity, compliance with state HCBS rules, and correcting any issues you find, and then also providing annual and updated staff training on corporate compliance policies, code of ethics, and documentation requirements. OIG has recommended 7 basic elements of a compliance program. The first one is conducting internal monitoring and auditing. So creating an audit plan that you reevaluate regularly that can help you identify your organization's risk areas. It can also focus things that aren't necessarily money, but what caused the problem, and allows you to create corrective action plans to fix any problems you find through that auditing process. The next one is to have actually implemented written standards and procedures, and then review those and make sure that they're doing what you intended them to do, that people understand them, they know what they're supposed to do. The third one is to designate a compliance officer or contacts to monitor compliance. So in a large agency, that may involve several people. It's always important to know, what positions really have the ability to monitor this effectively and know what's happening day to day. Conducting training and education on standards and procedures, knowing that your staff understands the services they're providing, what they can provide, what they can't provide, doing regular training on the documentation standards. Also, don't forget to train your board and yourself and any other compliance staff on, really what are the requirements, what are we responsible for, what should we be checking on a regular basis. Fifth one, obviously anything you find through all those processes, you want to respond to appropriately. Fix whatever problems you detect. If you find something that is wasteful and you fix it, 2 weeks after you find it, you might even be in a situation where you never billed it, but you corrected it before you billed it. In any case, even if you did bill it, your repayment is going to be much less than if that went undetected for 3 years. Develop open lines of communication, both between the compliance officer and employees. Maybe in a really large organization, you have an anonymous hotline. Make sure that your staff know that they're never going to be in trouble if they bring something to people's attention. Make sure that they have multiple ways to bring it to someone's attention. If they feel that their supervisor is committing fraud, they need a way to let other people in management know that rather than going through their direct supervisor. And then the last one is enforcing disciplinary standards through well-publicized guidelines. Be very clear with your staff what could happen if they choose to commit fraud or abuse, that it could result in fines, exclusions, and in worst-case scenarios, jail time. So it's really important that they understand the rules and they provide quality services. If you suspect Medicaid waste, fraud, or abuse, you can report it to the Iowa Medicaid Director, the Iowa Medicaid Fraud Control Unit, or you can report it at the federal level to the Health and Human Service Office of Inspector General. Each one of the managed care organizations require that you report it to them as well. AmeriGroup is on chapter 22 of their provider manual. AmeriHealth is on page 37 of their provider manual. They also just sent out an updated provider reference guide on that. And United Healthcare also has a quick reference guide located in their billing and resource guide page on their website. So all of them really do require that you report it to them, and they're going to be looking that you have a strong compliance system in place to prevent waste, fraud, and abuse. If you have any questions about this presentation or what could potentially be considered a reportable incident, and you don't know who to ask, you can email technical assistance at iowaproviders.org.